Okay, so Rick Altinger, CEO of Gluco. We are focused on diabetes disease management. We have started, the first phase of our company has been focused on connecting to over 160 different diabetes devices. We have served, and we are now, after 5 years, we're in use at over 6,000 provider sites in 24 countries. We've served about 1.3 million patients. We have helped their interactions with their care teams and with helping them manage their diabetes over the years. One of the key hows to doing that is we interact with these 150,000 devices, 150 devices. The wine is kicking in. And we go to market both with provider groups, so Palo Alto Medical Foundation, Sutter Health, Mayo Clinic, Cleveland Clinic, and NHS pay us for our services as a workflow solution inside their clinic and to remotely monitor patients in some cases. We also go to market with device companies, so we have deep partnerships with them. Today there was a great clinical study presented in Lisbon at the EASD conference that included 39,000 patients that have used Gluco along with provider groups where, so it's one of the largest digital health studies in populations that's ever been presented. And it showed basically better outcomes at lower cost in diabetes. So that's who we are.
My name is Amara Kendale, and I run product and design at Livongo Health. We're a consumer digital health company focused on empowering people with chronic conditions to live better lives. And we started with diabetes. The reason we picked diabetes is because it's full of hassles, and so that presents a tremendous amount of opportunity with a focus on the consumer. What we've approached the market with is as you heard earlier from Lynn Chow, a hardware, software, and services solution. And we take it to payers. We take it to risk bearers. So we work with over 200 of the largest self-insured employers, including over half of the Fortune 50. We work with 4 out of the top 7 largest health plans. We work with 2 of the 4 largest PBMs. And so what that's meant for us is that we've been able to focus on aligning value. And that value is to our users. We call them members. They're the people using our service. It's our payers. In the case that they're the employers, it means that they're offering the service to their beneficiaries, their employees, and their dependents. And the way that the service has worked is, or the way that the growth in the service has worked is because by reducing these hassles that our users face, it's meant that we could encourage and empower them to take the behaviors, participate in behaviors that are going to produce better clinical results. So for diabetes, it has a lot to do with checking your blood sugar and knowing where you are. It has to do with then using that data, which we get in real time through a cellular connection from our meters, to act on it. And so creating that moment of impact, that point of impact, has been very important for us. Interactivity is another really important part of our service. So not only do you get your number, you also get feedback in the moment. And constructing that in a way that reduces all the friction and the experience has been a really important part of the success that we've seen so far. We've also learned is that people with diabetes have other chronic conditions, and I think that this is going to speak to some of the themes we'll talk about later when it comes to addressing the needs of the whole person and acknowledging that a person with a chronic condition, for example, isn't just dealing with that chronic condition. They're dealing with a number of other issues in their life, and so addressing all of those ends up becoming important if we really want to drive healthcare improvement, which ultimately produces cost savings.
Good evening. I am Todd Johnson. I'm the CEO of HealthLoop. HealthLoop is a patient engagement platform that guides patients through acute episodes of care. So we talk about chronic disease management or wellness. We really focus around helping to guide patients through hospitalizations. And I think there is a ton of low-hanging fruit in the ability to achieve better outcomes at lower costs when you focus on these teaching moments, these acute episodes of care. We've had a lot of fun, and we now actually know without a doubt that patients that are put on the digital interventions that we provide get indeed better outcomes at lower costs. I'm also a fairly angry and pissed off individual. I've been in healthcare for 20 years. Every year I learn that under a rock is another billion-dollar cluster. And I think when we talk about the transformation to value, we spend nearly $3 trillion. Remember, cost reduction on someone's P&L is revenue reduction on somebody else's P&L. And until you can appreciate all the moving parts of this thing, it's hard to build your business. And I think you have to, is Lynn still here from Kleiner? Maybe she took off. I think she was totally wrong that you have to be able to like find ways to serve multiple parts. Yes, you do, but you also have to have a point of view. And you can take a lane, an opinion in this space, and if it's the right lane, you can win. I believe, and our company believes, that when you're sick, when you're newly diagnosed with something that's scary, when you're injured, when you need a doctor, the person that you depend on is not your employer, it's not your insurance company, it is your physician. Your physician has the power of the pen. And I think one of the big failures of the delivery system, and I apologize, I'm a big regulatory nerd, I'm pissed about the regulatory environment, I think our payment model sucks. I think what you can see with crystal clear vision is when you empower physicians and let them make smart decisions and give them the economic incentives where if they do the right thing for patient quality and give them a margin, they will make the right choice almost every time, and things kind of improve. So because of that, that's the business lane, that's the model that we choose. We empower physicians to make smarter, better, easier choices and enable their patients to stick with them and hope that together they get better outcomes at lower costs. So that's the blue team, now the red team.
Well, can we change colors? So, we're all blue team today. Hi, I'm Stefano Bini, and I won't belabor. I'm trying to think of what can I tell you. I usually tell people, don't mind me, I'm very opinionated, but then there's Todd in the room, so don't mind us, we're very opinionated, and we're good friends. It's fantastic to have him on this panel. I'll tell you 3 things, and maybe other things come out. I got my administrative chops at Kaiser Permanente. I spent 18 years there as a physician. I became leader of several departments. I went helping run hospitals, and then went up on a team that ran all the hospitals in Northern California and deployed Epic and looked at creating metrics and driving change. And at the end of that, I wrote a small book about driving change in healthcare, because it's not the same as driving change in almost any other system. And as a quick parenthesis, I go off healthcare. I don't think anybody on the panel earlier knows what value-based care is. It drives me crazy they all left the room when we could have taught them. But it's so classic of venture capital firms that don't employ any physicians. But then they will invest in our business. So it's okay, it's good, it's good. They'll wake up eventually. But the second thing is that I had a long interest in technology. Started back in the 90s with a company selling costume jewelry to women. Loved that business, but I didn't finish it up. I went back to med school. But when healthcare started getting hot again, I started getting more engaged and worked for Nokia when they were trying to get involved with the healthcare. And as part of the consulting, worked on startups and did some research and realized there was no research that was valuable in the healthcare space. So I've started publishing real, true, randomized control type stuff, including with Todd, that's getting a tremendous amount of attention because it's necessary. So then I moved to UCSF. I'm now a professor of orthopedics. I spend more than half my time doing complex adult hip and knee reconstruction, which has been a lifelong passion of mine, and it really does drive. And for those of you trying to get into the healthcare space and helping people get better, it's really gratifying. So you're doing the right thing. But the other half of my time is trying to work with my chair and those of us in our department to create a digitally enabled healthcare experience within orthopedics at UCSF, and we get a lot of support for that. And we're really looking to identify best technologies to integrate into our system to the best that Epic allows us. Now, yeah, you got that. And beyond that, I'm on a sort of a mission to point out that for those of you looking to attack healthcare, one day you wake up and realize it's a really big problem. And you might do what you do in every other aspect of your life, is you'll focus. and you look and say, maybe we shouldn't look at the entire breadth of healthcare. Maybe we should look at verticals. And you guys took diabetes, and if I can plug DocSF a little bit, I started a conference which is designed to bring attention to the vertical of musculoskeletal care, which goes from wellness all the way to trauma, and encourage healthcare systems, companies, big organizations to take their assets and focus them to one vertical, integrate them in that vertical, learn from that vertical, and then move outside. And that conference happens just before JP Morgan, and it's small, it's only for sort of leaders. It's designed for leaders who want to make change, and we encourage you guys are sort of my target audience, so hope you guys look at it, HP, and maybe consider attending. Thanks.
So I'm Jim Winkler from Aon, and I'm probably going to be a little bit of a contrarian. So for starters, I actually hate the whole stovepiping vertical strategy, because I represent employers, and employers have vendor fatigue. So all of you that have a cool solution, you're getting ready to go sell to employers, they're really frickin' tired of hearing from the vendor that can fix diabetes and like the left-handed, Italian third-generation American. Like, we need broader solutions, and we need a better way to pull all this stuff together. Now, that's not to suggest that great solutions that are out there, including the ones on the team over there, don't play an important role. They do. I think the important piece is the role that folks on my left and my right play in helping to integrate and bring all those pieces together. So one of the things that you'll hear from me as we talk through this is the role of sort of integrators and navigators and aggregators, whether that's the physician or the employer or a third-party entity, to pull all these pieces together in a way that allows the patient to not have to think about, oh, now I have X condition, oh, I think I have a new vendor for that, or the physician to have to think about that, but to have that all happen seamlessly for them. So that's a big theme for us, is as solutions get very specific, how do we pull those pieces together in a way that is really compelling? I totally agree, with Todd. The tagline I always use is one man's cost savings is another man's income reduction, which is why things change really, really slowly in healthcare. We're 18% of the United States economy. We employ somewhere in the neighborhood of about 30 million people, including all of us hanging out here tonight, and therefore change happens really, really slowly. That's not a bad thing, right? It might be a bad thing if you're a venture capitalist, but that's not a bad thing. We have to figure out how to do this in an intelligent way, because we're dealing with an issue that is very, very personal, emotional, and intense for people. Whether that's, I've been told I have cancer, or I'm trying to lose weight, or somewhere in between. And so I think it's okay for us to realize that the system moves slowly because there's a lot of stakeholders, and all of us are trying to figure out how to navigate around that.
And hello, my name is Katie Simpson. I work for Sutter Health. We're a system of hospitals and clinics serving 3.5 million people in Northern California. I work on the design and innovation team, so our objective is to make our healthcare system more simple, engaging, and human for people, while in the process making it a lower cost and yielding higher clinical quality. So we do that by doing a lot of ethnographic research. So starting with people and understanding, as you're going through life, what are you experiencing, and looking at what you were saying of those moments of high confusion and anxiety where we know that those connections aren't getting made, and we try to make them either through internal service design or external partnerships. So where there are problems that we know we really need to solve for the people that we serve, but that we logically should not build those ourselves, looking to external partners to understand what they do and how to link them seamlessly into the system, so for providers and for people, they can access them easily.
Well, I have a question, and I'll start off with my team. It's actually something that Todd touched on, but also Jim, and of course you work with many providers, the team over there, well, here too, but Todd mentioned that really you have to focus on the physician. And I want to bring this, also tie this into what Arshana brought up earlier today, which was the challenge, which is the challenge with physicians is that when they move to a value-based care model, they have lower compensation. So how do you deal, do you see that as a challenge? How do you solve for that? And then maybe you can also respond.
The good ones don't have lower compensation. I think that's first and foremost, and I think some of the program designs, to talk about value-based care in a broad way is not correct. Like, I think you need to break it down into the primary care models and then the acute care models, and there's dozens of different program designs. Some have proven to be much more effective than others. I think that just to take a shot at physicians, even though I love them, they got themselves into this mess, right? The AMA, like the history of fee-for-service was awesome, right? And so now we have to deal with the consequences. The good news is I think largely physician and clinical leadership is leading us out of this mess. Largely we're using fairly practical programmatic thinking about the effectiveness of these programs. I think Emily Melton earlier said, I can't believe, bundled payments got stalled in the regulatory environment. Of course they did. The people who are losing on that side of the P&L funded Price's campaign twice, right? But it turns out that that's a program that works. Like, I'm going to put you on the spot. I'm going to ask you like 4 rapid fire yes or no questions. Okay, ready? You.
Oh.
When given the opportunity to go for a risk-based, value-based model, did UCSF do it? Yes or no? You did it voluntarily, correct? Okay. Do you have better cost? Do you have cost reduction?
Yes.
Do you make more money?
Yes. No, well, it's qualified because the way we structure the way our particular department is structured and the way we work that out with the hospital.
Does UCSF make more money?
UCSF.
Okay. Okay, that's their fault for not sharing it with you appropriately. Last question.
No, that is the answer.
That's right. I'm right. Last question. Do your patients get better outcomes? Unknown. Are they worse than they were before?
No.
Is the total cost of care lower?
Yes.
Okay.
Sorry.
Yes.
So I mean,
give
that's
numbers on that
it,
too.
right? Like, that's it right there. When you shift the obligation to the responsible party, lots of great things can happen, and that responsible party can do good things.
Here's the piece where I think these guys. So here's the deal. A lot of these situations when you do shift, you said it earlier, you need to incentivize the physicians. Now, I know for sure, because I just got the numbers last week, that after I got to UCSF in 2015 and over 2016, I actually activated a bunch of things that led to a lower length of stay. You guys being part of it, because we have HealthLoop part of it. At the end of the day, that saved them $2 million. None of those, first of all, I didn't know until I looked it up. Secondly, none of that came back to the physicians, right? So if they want me to save another $2 million, let's say if they gave me 10%, not me but the department, do you think I'd be more incentivized? That's not going to happen. We're going to get an award or something. So, but that's sort of like, to the extent that these value-based payments really are more bundled payments, the value-based care is a different project, but the bundled part of it, with the extent where a lot of the healthcare systems are, especially take the highly profitable service lines like ours, and drive all these improvements, but don't have a cost sharing agreement, benefit sharing agreement, are not going to see the same improvements than when there is one. Do you guys want to comment on
that? Well, going to the incentive piece in terms of money is one incentive. There's also the how do you flow through your workday incentive. So speaking from the outpatient care perspective, one of the things when we bring certain solutions to our care teams and say this solves for a patient need, this could be cheaper, what do you think of this? This isn't an explicit thing, but this is something that gets said, is just if we, for instance, if there's a telehealth solution or a coaching solution that does something for patients that would have otherwise been done in a low acuity visit, that's something that patients can come in for. It's a little bit of an easier portion of the physician's day. When you take away all of those things and outsource them somewhere else, one thing is that some providers feel like it deteriorates the relationship that they have with people. The other thing is that it means that all of the other visits in that day are all very high acuity visits and stressful. And so that's another piece of the incentive that comes into play when you come with solutions to providers and have to consider that as well.
I think the one other thing I would add on value-based contracting in general is that it is rare that any one facility is the most cost-effective and highest quality for everything that it does. And so to some extent, to really do this well, it has to be sort of, condition specific. So now I'm going to put my employer representative hat back on and God, is that complicated? Like, how do I explain that to my employees? And like, I want you to go here for this kind of service, or here for that kind of service, and so it gets really complicated. But that's, at the end of the day, if you're going to truly drive change, you have to recognize that some facilities are really good at some things, but not at other things, and you don't really want people going there.
I think one of the things we're doing, though, is we're focusing on providers who spend, 0.1 or less % of their time, a member, a person's time. People just don't spend time with their doctor. You hardly see your doctor. So yes, it's important, and everyone loves doctors. It's like motherhood and apple pie. You can't say you don't like your doctor or that doctors don't care. But the incentives are not crisp. There's an enormous amount of abstraction. Your example, Stefan's a great one. I mean, the fact that there's a stick, right, which is the doc can get penalized, right, but there's no carrot. And without having feedback loops that actually work, you're not going to see change. It's definitely not wide-scale change. And pointing to UCSF is great, but UCSF is an outlier among providers and among health systems. So if we actually start to frame this in terms of timescales and where we're going to see impact happen, while there's many, providers with the right motivations and the health systems with the right goals, they move too slowly and the motivations are not clear enough. The financial results are not clear enough to drive change fast enough. So there's two other parties that we have to focus on. One is the person with the condition, issue, et cetera, the person who's actually dealing with their own personal health care. They're very motivated, and they don't have time to wait or waste. And the other is the payer, the entity that's actually, shelling out the dollars for every single cost of care. And so I think I'd love to hear some of the feedback on that, because I think we need to reframe the problem away from the provider, even though we've always thought about healthcare as being sick care and provider focused. The model has to flip, and it has to be a consumer-focused well-care model, which means that all these things we're talking about need to change.
So I think from the perspective of the discussion that's happening, what happens is value-based is investment that doesn't reach the CIO or the CFO of the hospital as a need for the provider. When I say PCMH, I also mean patient-centered medical home and provider-centered medical home. Because it has to be, the two of them need to be the core of decision-making. Your most trusted source, in a way, for making choices for you is truly not the employer, it's actually the provider. And it is true that maybe we can drive solutions that are more standalone to empower them, but I think the provider needs to be at the center of this. And what happens is most of the organizations, they are in somewhat of a pyramid scheme, and it does not trickle down to the people who are doing the legwork for the patients.
So I'd be curious on your thought. It's interesting idea, the P, provider, physician. There's some people have been talking about this concept that the physician should move away from being God to coach. They go into a peripheral role. Is that where you're seeing it going as well?
Yes. So most of PCMH models, their primary care on steroid models, the provider is really the coach, and they're nudging and guiding them in the right direction. So in another company, in another place, our experience, for example, with Livongo, could be that the provider, if they're aware that their employer and their ecosystem is offering Luco or Livongo, go and get that data for me so that we can integrate these services. This is where we grapple with, having things in silo. And that is my question for both panels, that why should an employer invest into solutions or vendors solutions that are sitting in a silo, and not just go and get a great solution, an ACO solution with either Sutter or UCSF. Why should we invest our money into PM model, into a solution like standardization?
Yeah, so I don't think you should. And I think the PM model is broken, where you pay a certain amount per member per month. I don't like the word member. I like the word patient. Patient is who Dr. Beanie sees, right? It is that patient-provider relationship and the power of the white lab coat that's the strongest. And I think you should invest in entities that tie in with the ecosystem. And I would, highlight Sutter Health, by the way. I think they recently are doing some things that are really in the right direction. So first of all, they are investing in coaching. So the physician health services and the coaching services model that they have, and their ability to directly contract with employers for that, so that when the patient is not inside the clinic, they have a solution for those other 360 days a year. The other thing they're doing is they are leveraging, so it's not just a standalone coach that's unrelated. It is part of the doctor care team, so they can tie in with the Epic system and see that data if the patient is there. But if not, they understand physician workflows. And so if the patient is in Minnesota, if it's an HP patient that's in Minnesota, they really understand the importance of connecting in with the Mayo Clinic physician or the Fairview physician. On the flip side, one of the things that Sutter Health, and I've not met before, but the other thing Sutter Health is doing that to me is really interesting is they've partnered recently with Aetna around a risk-based model. And Aetna understands in their other risk-based models that they have partnered with physician groups. What is one of the first things they do? They said, what is the incentive plan for the doctors? How much of this are you going to share with the actual hands-on people, the people with white lab coats and rubber gloves? If we're not going to share with them, they're the people that have, spots on their shoes because someone threw up on them today. They're the real people in healthcare. And if you're not going to share with them, then you're really not going to implement a true value-based plan. So I really applaud Sutter and some of the changes that they've been doing recently to engage with patients ultimately and leveraging their provider and their brick-and-mortar providers, but then the coaching services and then the partnership with Aetna.
Can I just answer your question a little more? That was very good, thank you. But and Rick and I go way back, as it turns out. So back to this concept that healthcare is really a lot bigger than just it can put in a box. That solution was very good for the company invented it, which is Walmart. I mean, they've got employees in places where there is no good care. They were seeing patients get mistreated and readmitted and readmitted and readmitted. So they identified an opportunity to create these narrow verticals that met their needs. It's perfect. You would never do that in San Francisco. That makes no sense at all. You got UCSF, Stanford, you got Sutter, you got all these opportunities. You go up north towards Lake County, you might say, okay, maybe there's an opportunity, but there's no employers there. So the point is, it was a solution to a problem for a company that is very creative and thoughtful, and I think it'll work well. Is it the right solution for HP? Probably. I suspect that HP is in large centers of excellence nearby, so you probably don't need that. So the answer is yes, it's the right solution for a certain type of employer, but definitely not for anybody who lives in a large healthcare environment, rich environment.
I have a question for Jim. If you think about your customers, your employers, what fraction of them are actually capable of doing something like this, building an ACO model? I know there's FedEx and there's a couple, but they're very large, very sophisticated. They understand how to enter into risk-sharing contracts themselves and develop relationships with risk-bearing providers. The question is this going to scale and how long is it going to take? Because what we see is that we're a ways away. And if you look at the other end of the spectrum, the only other entity that's actually pulling providers together is the health plans. That's their business. That's what they do. So those are really the two options, and I'm curious what you think about where we are.
So in the earlier venture capital conversation, someone made reference to Walmart and a few others, and they talked about those as Fortune 50 companies, and sort of under maybe not totally under my breath in the back if anyone was near me. I said no, those are Fortune 10 companies, right? I mean, that is a very different dynamic. There are not a lot of organizations out there that have the market dynamics like you just described, right? So what Sally and her team at Walmart did fit what Walmart needed, absolutely, right? There are not a lot of organizations that have the benefits team depth and or the consulting budget to go do those kinds of projects. And so then what you find is the next sort of tier of employers are doing direct contracting more around like a center of excellence for certain services, right? We've been doing it for 25 years for transplants, now doing it for other things. And then you start to go below that, and you pretty much then get into the health plan world. The challenge with that is, if you have 4 national health plans, you have 6 different definitions of ACO, right? And they're all contracting differently. And so that's part of the challenge that we're facing. Where I think a lot of employers are starting to go is a recognition of saying, okay, I'm going to try to work that system through my health plan, but in the meantime, I'm going to try to look at other data sources, other tools and whatnot, to really guide and direct my employees toward the better physician, the better hospital for a particular condition, even if I don't have a true ACO kind of contract in place, just to make sure that I'm driving, I'll drive towards value-based care, even if there's not a value-based payment model behind it.
What percentage of the employers that you work with or see have some sort of ACO in place or this network in place?
So I'm going to readily discount my own survey data, which is a weird thing to do, but I'm going to do that because I think most employers don't have a great understanding of what the definition is of having an ACO in place. So so the numbers are weird. What I would say from our survey data, when we really look at who's actually engaged in some form of value-based contracting that's not just a bonus for great performance, right, which is cost additive, right, but a true value-based contract, that number is probably in the 15% or lower range. Right now, while the health plans will tell you that they're paying somewhere between 50 and 75% of their claims are being paid under a value-based contract. Right. So if your customer is saying I think it's 15% and you're saying it's 75, there's a big disconnect.
But there's 15% that would buy their services. Just those 15% would do direct.
No. So those are employers that are thinking about patient-centered medical homes, either real health plan-driven ACOs or direct contracted ACOs. Those are not employers that are thinking about. So there's some of this is terminology. I don't think a lot of employers think about a Livongo or a Glooko as a value-based contracting strategy, so much as they think of it as a strategic health improvement, patient utilization, patient experience strategy. But I don't think they would chalk that one. That's not a tick box on, I have Livongo, so therefore I'm doing value-based care.
Although I would say that, we are seeing much more interest from employers, but probably more importantly, health plans in risk sharing. And so we're ready to share savings. And, we have the data. We do our own claims analysis, at the end of every year. And we're ready to put our money where our mouth is because we're bringing all this data back. We're heavily connected. It's a virtual network, and that means that we get a lot of data back ourselves. We can operate much more quickly because we're getting real-time data than the health system could. And so that's the arbitrage opportunity. So if we are getting data much faster and we can act on it much faster than the other risk-bearing entities in the ecosystem, there's value to capture and there's value to deliver. But I think the other thing that's interesting about this kind of broader discussion about whether value is going to originate with the provider or whether it's going to originate with the payer is that the payer owns the beneficiaries. Like, they are responsible, financially responsible. And so the direct connection to the object to put it in sort of backwards terms, but the direct connection to the person who's in need of the benefit is far more important to control and to manage than a more diffuse and distributed relationship between an entity, perhaps in a geography that perhaps touches some fraction of the people that the payer is covering. So, healthcare is a local business, and so their employees are distributed all over the place. I think all these things we're talking about are beautiful ideas for a future that's still many, many years away. Unfortunately, I think decades away, where there's these highly granular ACO contracts between every employer and every provider in a region. But that's okay. We have plenty of other things we can do in the meantime. Ultimately, I think the way we get there faster is if we can actually attribute the value, know where it's coming from, and then distribute it back.
Can I interrupt you for a second? Yeah. Because if you say value one more time without defining it, I'm going to get up and leave. Sure. Because this is one of those frustrating things to me as a clinician. What do you mean? What is value? Is it... You can't define it. Exactly. Not like you can define it, you can't even measure it. So now, we've all spent about a half an hour talking about value.
Personal experience?
Yeah,
what I want to say was that,
pull all of this together?
Can I just make my point real quick? Just 1 second. A lot of discussion starts on this issue of value, and then we build on that. Value, and then we build on that. We don't know what value is, therefore the entire structure above that is potentially...
So I think in this context, I think value is code for not value-based.
Yes.
Right? I think what we are really talking about is value-based versus not value-based.
From
Yes.
a patient's perspective, value is, I had a stomach ache, or my partner did, and he went to the doctor, and the doctor told him, you probably need us to stick things up your rear end and figure out what's wrong with you. You might die of cancer. He went to another doctor, and that doctor said, oh, you probably have an allergy. Why don't you try cutting things out of your diet, and we'll slowly figure out what the problem was. That was the solution. Now, I want to bring a few of these things together. Jim, I actually want to put your question back to these two guys, Amar and Rick. Your question was, how do you join verticals and aggregate them? So you guys do diabetes. That's really cool. How about things that people are allergic to? That's something that a lot of people get at 30, so you're hitting a target base of like these companies like Google who have 30-something-year-old employees. How do you add that onto your system? What are the problems? What are the challenges?
Yeah, I mean, it's a hard thing to do, to be honest with you, because you have to be focused. And diabetes, the reason why there's two companies that are well-funded in diabetes is because, A, 86% of our healthcare spend is in chronic diseases. Diabetes is the single largest chronic disease, particularly when you look at its, how it is the root cause of various cardiovascular diseases and stroke. So my answer to your question is, I, as a company, don't. I want to stay focused on diabetes and stay focused on the single largest chronic disease, rather than try and do all things to all people. Well, I've got the mic, by the way. In terms of the definition of value, I do think I want to point out that in all these value-based care arrangements, the unfortunate thing is so little of the real dollars are in play. So with the Medicare-oriented accountable care model that has now been started to be adopted, I just want everybody to realize it's like a tiny little bit of a provider's total revenue is either at risk or available to be paid in some sort of bonus payment. So it's kind of a meaningless thing. It's really, so for a self-insured employer, you're getting marketed, right? The big payers are saying, 50% of my reimbursements are associated with a value-based plan. Well, that's just bull, because what percentage of the dollars that they pay out are in conjunction with that? It's like 1%, if that. It's a meaningless number. If someone wants to really partner with you, they need to put 50% of what their dollars, and both Livongo and Gluco are willing to do that, right? We'll put a big percentage of the total revenue we receive at risk. The health plans aren't willing to do that.
Small number on the grand scheme.
Sure, but in diabetes, given that it's 16,000, it's your most expensive chronic disease, and you average about $16,000 per patient, it's a big number that we can have an impact on.
Yeah, and I think that brings us to the point of decision tools, right? So even for a payer, the decision tools are truly all missing because there's no transparency in that cost flow or the dollar flow that we don't get to see. And of course, Jim helps us out quite a bit, but that's something that we would like to see, the transparency tools there. For the patient too, there are no real transparency tools built into or integrated into the system. Like, for example, if you're doing care coordination or decreasing the rehospitalization with a solution, or bundling payments for replacement, joint replacement, which is actually a big spend, the patient needs to know where to go. The patient needs to know where is the value. You ask the definition of value. The value is great care at affordable cost with compassion. And that's what the perception of the patient is. And that's essentially what you and I got trained to do, is to exactly do that. But the whole medical health system, cost was never a concern and never a learning through medical school. And what happens is you throw these physicians with a very powerful pen in their hand and with the intention to help patients. And then with a lot of books that they've read, but not so much of evidence-based care modeling and the tools that would help them to decide what's the first thing to do. And we're looking at models in which physical therapy first. People can self-refer themselves for back pain and physical therapy. They don't need to see a doctor. And those are the things that we want to do. And in that way, we can shave off the cost of overutilization, like you mentioned, colonoscopy. I don't think we look at also procedures as cost cut, that how many procedures somebody is doing. Is that validated? That actually was the reason why we're moving from fee-for-service, because and the doctors called upon themselves. I agree with that in a way.
If it doesn't get adaptations, I'd love everyone to respond about that, because I think in the value, now I'm nervous to say value. But anyway, but in this new model, everyone sort of takes risks, everyone understands the costs, and so with the patients and patients for the longest time have always just looked at their insurance companies to pay for. They don't know their costs. So in these new models and with your new services, how do you get the patient involved in sharing in that risk? And are there incentives for them now to actually make more decisions?
There are. I've got a great comment. So I'm going to backpedal on saying that Lynn was wrong earlier and say she's right in one domain. I think healthcare providers are reluctant to move into at-risk models because they're scared, right? It's a nervous thing to do to start to put your revenue at risk. One hospital, I'm going to name them, Mount Sinai in New York City, which is, classic academic medical center, big bureaucratic, can't make decisions, lots of fee-for-service business, big business. For the first time ever, I heard a really cogent argument around how and why to be deliberate about moving to more, and I'm not going to use value-based models, I'm going to use the word affordable models. And what I think was so interesting about their argument was it actually doesn't matter if we continue to run up charges. With increasingly our health plans being high deductible health plans, as individuals, you're responsible for that 20% copay. Their concern was the cost of services were going up so high that they would become unaffordable for patients just to make up their portion, right, let alone the whole pie. And so they have started to try to differentiate themselves in New York City as, hey, patients, we're looking out for your bottom line and trying to reduce your costs and your copay. And it's a sort of a simple thing. It's like the buck stops with the check that I have to pay. I mean, part of the problem is you don't know how much you have to pay until you get the bill, and actually it's 12 bills, right, after you've been admitted to the hospital, and you get them 90 days later, so that the gap there is a challenge. But patients bear an extremely high amount of the cost of medical treatment, and it's only getting higher. And once we become aware that we have some choices that can actually impact the amount that we pay out of pocket, then it'll become easy for us to make decisions.
I'd like to say really quickly about your comment about health systems being afraid to get into risk. I would say that it's exactly the opposite for us. And we've been trying to move into it as much as we can in terms of starting our own health plan and the JV with Aetna. And if we could flip everything over tomorrow, I think that we would. There are a lot of things that we want to do that we know are the right things, that because we're a community not-for-profit provider, we serve anyone who comes to us. So as long as those PPO plans are still out there, as long as fee-for-service is still something that people are choosing at open enrollment, that's still something that we're going to serve. But we certainly would really like to have all of our patients being under the same incentive bucket and be able to adjust our operations. So until that time happens, we're investing in risk-based things, or in things that make sense under a risk-based system, but not under fee-for-service, because we know it's the right thing, and trying to make that flip at the right time so we make sure that we don't spend it all before we can get reimbursed. But to certainly move in that direction, because we want that to be the right thing.
It's the ultimate at risk. It's the ultimate. It's been around for 60 years, super profitable, super effective, great results. I kept my Kaiser insurance after I left. We don't have to look very far to see how that would work, right? We have it in our backyard.
It hasn't been as successful outside of California.
Mm-hmm. Oh, but that, yeah, we can talk. I don't think I want to hear about that. It's an interesting discussion.
No, I think I also wanted to mention why providers feel nervous about moving to a risk-based model, partly because there's a disconnect between the providers and the administrators and the CFO office in general. And I think what ends up happening is we do not know that the health system is going to support their activities that are driving them to outcomes. And that is something that we constantly hear from the medical directors.
I'll say the smaller groups it is impossible for them to assume risk, because they get one bad outcome and they're out of business. You have to be a large group to take risk. So the vast majority of care is still not delivered in large groups. Therefore, until that question is identified, until you can share risk.
I think the vast majority of care,
That's what
when I got into healthcare in the early 90s, 85% of physicians worked in groups of 10 physicians or less. Now it's flipped. So the vast majority of groups of physicians and care are, and that's a key building block, by the way, because entities, in the early 90s, Palo Alto Medical Foundation, Sutter Health was a tiny little entity. They've now rolled up, Stanford and all the other groups. I think that's a key building block for us.
In California.
In California, but it's also happened in Boston with Atrius and Women's. It's also happened in
Posts.
So in Kansas City, one of our big at-risk clients is in Kansas. It's happening, though. And I think, by the way, let's see what happened to Sutter. One of the reasons why they're so interested in risk is because, A, Kaiser has been successful here, so they've lost a few patient encounters to them. B, I think it was a year and a half or 2 years ago, Blue Shield of California said, Sutter Health is no longer in our network. For about 3 months there, my wife was really nervous about it because we have Blue Shield of California. And I think now they figured it out, but I think that was one of the wake-up calls for Sutter to say we need to go faster. We need to look at partnerships with people like Aetna. We don't have the internal people that we need, and I think we're starting to see it. Atrius in Boston is doing the same thing. Mercy in the center of the country. Kaiser and the costs are causing finally for these physician groups large integrated health systems. Advocate in Chicago is another one.
Well, and
Speaking of risk.
Innovation starting to happen into the direct-to-consumer. So we're starting to see One Medicals to come out. So you're talking about bigger systems, but there is a lot of, starting of these smaller practices, but they're supported with a financial model that is a concierge model, in which they're able to finance their, to sustain themselves. So if they have one poor outcome, that doesn't wipe them out. They're able to sustain and weather that. So those are other things that we're starting to see, IORAs or One Medicals, that are bringing value and directly going to the consumer saying, we'll sell you value.
But they're only selling value on the rebar, right? So, Clay Christensen. So it's like, okay, maybe they'll grow, but they have to grow to be able to assume that risk. So I'm going to hold on to my point. I think that you talked about the major population centers. I think you're right. But there's 360 million people in this country, and we just got to forget they don't live in Palo Alto.
So I cannot not interject with this question. We've talked about risk so much, just like you asked about value, right? It seems odd to me that we're a bunch of mostly scientific people sitting here, but we are assuming that risk is this thing, and we just have to, it's like a hot potato, we just have to share it, we have to pass it on, it's the payer or the provider. But why aren't we thinking more about really understanding these small practices that would not take risk contracts, right? But they would if they understood the actual risk of their patients. If these providers went to the payers with a solid knowledge of what is the actual risk, what is a patient level risk, and they're able to negotiate at a very specific risk-adjusted compensation, it seems more obvious to me that risk wouldn't be such a thing that we're all kind of hot potatoing around. Now, I know the insurers are supposed to be the actuarial masters at this, but that's too generic and population level, right?
But, so I'll start with that. So I work for Aon, and as much as I love what we're able to do in the human capital space when we work with organizations like HP, we're actually a lot bigger in the property casualty risk transfer and reinsurance space. We work with about 400 hospital systems across the U.S. Some of those we used to be just like the, med-mal insurance broker, but now we are their risk consultant focused on things like cybersecurity, which, by the way, is a massive issue for this industry that nobody's paying any attention to, right? Everybody's worried about breaches at Anthem. Wait till we start breaching, hospital systems, because it'll happen. So cybersecurity risk, payment risk, like this sort of revenue transformation risk. And so we actually are working with the reinsurance marketplace around the world, which has massive amounts of capital it wants to invest in the United States to create basically risk mitigation products for provider groups to kind of bridge over. Because many would say, like a lot of the hospital CFOs that I talk to would say, I get my P&L today, I understand the good, bad, and the ugly of it, and I can see how I could be successful in a payment for value world 5 years from now. I'm scared to death of the transition. And so we're working to figure out if there are ways we can bring
Well,
reinsurance.
the problem with
products.
generic risk, right, is that an individual specialty like an orthopedist or, let's say someone who's an endocrinologist, they don't really understand what they're signing up for. We've talked a lot about the trickle down to the individual provider. Unless they know for their specialty what risk are they taking, how much service do they need to actually provide, and we have the data, right? We have the literature, the evidence tells you what's a bigger risk factor for certain things. Like, it's not perfect, but the part that I don't get is, a lot of us are working on the assumption that the risk will always remain unknown, and we remain unscientific about it.
Practically speaking, there's a chicken and egg problem that the industry is facing. Providers in particular have made enormous investments in getting electronic, right? So electronic health records are just making their way across the entire space. All the stuff that's sitting behind that, population health management, all the things that put information in the hands of the doctor, we're still years away. And the chicken and egg is that unless they take the risk, they can't afford the population health management tools.
Well,
And they can't afford to take the risk unless they know where the population is. That is creating a bit of a pause right now in the way that the market's able to invest.
I think one of the challenges is we haven't used real-time risk models to alter treatment, right, in the past. So it's a new thing.
We can read your side.
So
Did you hold up the sign for everyone? I just like to point out this is a gender bias statement.
yes.
I can keep talking.
Explicit gender bias.
I like that. I'll keep going. Sorry, I do want to hear your thought real quick.
By the way, when we talk about this topic, I think you talked about patients, we talked about providers, and we talked about the purchasers. There's another P that we've barely touched on, which is the pharmaceutical industry. And in diabetes, it's a pharmacologically driven disease, and I think the pharmas are willing and are engaging in true value-based contracts. And I would encourage, the self-insured employers to, somebody like yourself specifically, not, the rank and file self-insured employers, but someone that has a physician on staff that can understand things, to engage directly, with your largest chronic disease, by the way, which is diabetes, and, specifically Novo Nordisk, right? They are, in diabetes, we spend about $35 billion a year in drugs. Novo Nordisk has about 16 billion of that. They're 2.5 times the largest, the next largest Sanofi, and Sanofi is sort of losing revenue. So I would encourage you to work directly with them. I can make the introduction for you. They are willing to go at risk at this point as well, and they're key to this solution.
Okay, well, as the risk.
Quick question on that point, because that was my last question is, $300 billion well-capitalized segment of this industry, pharma.
Yeah.
Are they friend, enemy, or irrelevant?
Certainly not irrelevant.
They're certainly not irrelevant. They are both enemy and friend. So it depends who you're talking to. There are groups inside of pharmaceutical companies that are enemy. But I can tell you specifically, if you look at Lars, the CEO of Novo Nordisk, he is a friend. I mean, they're owned 60% by a nonprofit entity. So they are motivated, unlike any other pharmaceutical company in the world, in diabetes, because they want to help people and drive better outcomes.
So pharma would be hopefully our next topic of discussion, I think, because we can actually deep dive inside. Pharma is a relative who is also a friend and an enemy. You can just call it that way. And we have to work with them. There's no getting around it. So it is, and it's not like... drugs are becoming generic. They are becoming less and less relevant in the big blockbuster drugs that used to be before, and now they're no more. So they have to partner with the employers or the payers or the purchasers of health to make sense and get onto this relationship.
So
The reason for me being here, right, I have a use case, a particular use case. My son, he's 3.5 years old. He was running high fever, and we went to our primary care physician, pediatrician. He was there with her for 3.5 years for high fever. So first day we went, she checked all the basic tests, the flu and everything. Still the flu and everything came negative, but the next day again he was still running very high fever. We went to a physician. We went to the physician's office, and she said, better we take him to the ER. So we took him to the ER because we rely on the physician, whatever the physician said, right? So now we took him to the ER. Within 1 hour of ER, right, it was identified with the strep throat, the high fever. Now I have to bear with, I'm on the high deductible plan. I have to bear with 2,000, almost 3,000 on the bills, right? I filed a case with the medical board. It's still pending. It's going on. So my question is, the value-based care, right? I mean, in this case, how it could have been different?
Should have chosen Kaiser.
Well, first of all, it's not really value-based care, it's quality care, right? And, you know, I don't know how to answer your question, but I tell you that there's about half dozen companies that I've met where somebody had a problem like that and solved it with a technology solution that may be in a vertical, that may lead to another solution, leads to another solution that builds a better product. Like, I think that AI engines are going to really help us in this world when people at the front line start to screen things through an engine that really brings up the question that you think about strep throat. I don't want to defend the care. I can probably create an argument why that would be a perfectly good thing not to think about strep throat in that case, but that's not the point you're asking. I don't know if anybody else wants to comment on it. I don't think there's a good answer to your question, but I do think that sometimes problems like that have led to some really amazing solutions in the digital health world.
Yeah, and most of the patient-centered medical home solutions are driving people to practice at the highest level of their licensure. So, you know, in this case, if the doctor did not have an appointment, and I'll give you an example of our premise health center that is on site. So we had our providers are completely booked, and we came in with exactly the same complaint, 7-year-old child. And what they did was the nurse, the RN, goes in, screens the patient, does a strep throat. The parent still is able to take the kid home. Of course, with the culture, strep throat was negative. Our provider calls in an antibiotic, sitting with the patient, the culture comes back positive the next day, because that can't help it. The test was negative on the first day. So a couple of days later, the test is positive, the kid has the antibiotic, taken care of, no ER, no urgent care, not even a telephone. But in self-insured employers, we do push telehealth, we do push urgent care, and then the ER. So we do try to educate. I think patient engagement and health literacy is a nut that we would like to crack, because, you know, as educated as we all are, we still are making poor choices in our healthcare, solutions as patients. So I believe, you know, that's something that we can actually do as a vertical that we can implement.
So we talked about risk a lot, and so at the risk of not having enough time to have some drinks, I think I'm going to have to wrap this up. But I did want to bring up, we sent out a survey, and hopefully everyone took it, and then we'll take it tomorrow because we want to see if everyone changed their minds. But this has to do with risk. We'll play a little bit of Family Feud here. Has to do with risk and value-based bonus. So we asked in the survey, if you're a physician or if you're a payer, what % of compensation should be risk-based or bonus-based? So what do you guys think, and what do you think? Let's see if you know your clients and if you know your customers.
What is the state of the industry today, or what should it be?
Should be,
what's the
as an
ideal?
individual doctor, what % of their income?
What % of their income should be, and the payers, well, what % of their income should be at risk and should be bonus based? What do you think it should be? I'll tell you what do you think, first, what do you think the answer was?
So the question was, should be like eligible for a bonus, correct?
What percentage of providers' compensation is risk-based?
Is risk-based.
So out of 100,000 that they make in a year, how much of those thousands has to be linked to?
So I'll tell you the first question I asked before I'd give you that answer, if you're my employer, is that how are you going to measure quality? And how am I going to be able to manage risk? What tools are you going to give me to manage risk? So if I get everybody coming to the tendon in my clinic and I can't control that, I can get limited at 10% or whatever, I'm not going to at risk base at all. And I'll find another employer. To the extent that you give me a certain amount of control over the ability to manage that risk, then I'll probably take a lot of risk.
What do you think the survey said? That these are payers?
Depends how many physicians you had on your survey.
It was this group,
No, and-
right? It was this group.
So you probably,
This group, it's only the ones who were physicians and payers. What do you think the biggest number was that they thought, ideally, what they would do?
75, 80%.
What do you guys think?
Like 25, yeah.
It was 30%.
we can get there. I mean, I think with the technology being developed in this room, the more information we have available to manage risk, the more we'll take on this. And I think that is one of the promises of the future, to your point. Because even the interior people say, yeah, give us more data. We'll help you manage this kind of thing. Nobody wants anybody to fail this, right? It's just that we don't have the tools yet. One of the promises of digital health is that we're finally getting the tool we've always wanted to crack this code of managing disease. Because one thing we never talked about is this whole idea of now it's escaping me. What are we misusing all the
Value?
The value-based concept is that there has to be competition in that system. So you can't just have one group, say Sutter, go on a value-based. There's nobody else doing it. What are you measuring? My cardiac risk versus whose? You've got to be, even that concept with those competitors, and unfortunately that competition is actually the whole infrastructure is crumbling around. The foundation of defining risk, defining quality, defining access, which are the three pillars. On top of that, creating enough of people buy into that whole concept to be able to have valuable data that you can actually compare. Because frankly, one of the things that Kaiser does extremely well is show quality internally. And then we can see quality go like this, where 5 years, just imagine a graphic, you've got a group of hospitals at this level, and then 7 years later, they're here. So the lowest performer is way above the highest performer used to be 5 years ago. That's the Kaiser permanent story from 2000 to 2012. Right. And how did they do that? Data. All internalized. The whole building they built was great data. Yeah. And it was extremely successful. No punishment, no penalties, no dollars associated with it. It was just feedback.
The problem is the data is EMR data or billing data, and no one's getting that day-to-day data that happens between doctor visits. I mean, they're trying to in apps, but the use of apps, it drops dramatically after a month. Yeah. And that's a key, that behavior change, what you're addressing and what you're doing.
But Kaiser has long-term, Kaiser has the long-term data on costs, and so they can see really the health outcomes and the cost, which is two of the key parts to value. So I do think they have the data to see it.
And at least we need to begin with that data, right? So that data is not on the fingertips of the providers, or even the patient, or to some extent, even the payers. Even what is available is not available.
I would also say, show of hands, how many of you have, born and raised in California, lived here your whole life? All right, not as many as I thought, so that's good. Kaiser is really cool, but I live in Connecticut. I've lived my whole life in New York, Connecticut, and a little bit in the Midwest. Kaiser wouldn't work there. It flamed out miserably in the Northeast. It's a different model. And you mentioned Mount Sinai earlier, right? The Mount Sinai competing in the New York marketplace, where like people would rather have to go to Kazakhstan to get care than cross Central Park to get care, are not going to Kaiser. Okay, so the challenge with using Kaiser as the example is it's really awesome here, right? And it's pretty good in Colorado and pretty good in the Mid-Atlantic and nowhere else.
And the cost of the staff, I mean, with the unions, I mean, a lot of people don't realize, but 70% of costs of healthcare systems are employee salaries.
Yeah.
And they're going astronomical right now.
Sorry to interrupt. Specifically to the Kaiser, right? I had a case where I can't disclose right here, but I had to go out of Kaiser to do my test. And that's the reason someone asked me, right, why I'm not with the HMO or the Kaiser. That's the reason. I had to go with the external. I was with Kaiser. I was with the Kaiser, but I did not get any help from those medical practitioners. I had to go and look further. I had paid from my pocket, even though I was in the Kaiser.
So I think we maybe, Arshana, we should probably let everyone start.